Good afternoon, everyone. We welcome you to this session on what some people call your ticker, your heart. And we are thankful for your being with us on this afternoon. And let us pray. Eternal God, we thank you again for the chance for the Fifth Baptist Church, as well as friends and other community members to join us in order that we may increase our knowledge. Help us, dear God, as we continue to navigate during this time. But even, dear God, when the pandemic has subsided, let us continue to take care of our temples, take care of our bodies, in order that we can have life and have it more abundantly. In the name of Jesus Christ, we pray. Amen. Thank you for those of you who have joined us on this afternoon. We have as our facilitator, our workshop leader, our session presenter, whatever you want to call this. We have Mrs. Chanda Hicks, native of the big county called Halifax, Virginia. She received her training from the Danville Community College, and she is a nurse. And we want to thank her for joining us on this afternoon. She is a mother of two, and her husband will sell you even a Rolls Royce. He'll make sure you move from his dealership. If there's a Rolls Royce out there and you want it, he'll make sure that you get it. So Mrs. Hicks, it's all yours.
Thank you, Reverend Ricardo. And thank you for asking me to talk about the heart. I have been nursing for 24 years, and all those years I have dealt with heart patients in some capacity. So professionally and personally, I'm passionate about the heart. So thank you again. I just pray that today I say something that will help someone just not ignore warning signs and help modify and control some risk factors. So that's what I hope I can do today. I want to start out with a statistic from the American Heart Association. The American Heart Association says that heart disease is the number one killer in the nation. So the number one killer in America. But African Americans are 30% more likely to die from heart disease. So that is very alarming. So hopefully we can learn something today so that we can be more aware of our bodies and of our hearts. I'm going to try to share, Mr. Henderson, now. Share my slideshow. Okay. So the heart is often in healthcare, we talk about the heart and compare it to a house. So in our house, you have to have electricity and you have to have plumbing in order to have a functional house and to be able to live in it. Well, the heart is very similar. We have what we call the plumbing part of the heart, which are the arteries and how they flow. And we also have an electrical part of the heart, which is the part that you have your heart beat. So all of those parts need to work together for your heart to work accordingly, or work and pump the way it should. Electrophysiologists are a type of cardiologists that diagnose and treat the electrical part. And then you have interventional cardiologists that treat and diagnose and treat what we call the plumbing part of the heart. So it all works together to pump oxygenated blood from our heart to our bodies, to our organs, to our extremities, because all of our body needs oxygenated blood, even our heart. Our heart is a muscle. And we're going to talk about a little anatomy first. So like I said, our heart is a muscle. It's about the size of your fist, and it is to the left, a little bit to the left of your sternum, which is your breastbone, right in the middle of your chest. So to the left of the sternum is your heart, and about the size of your fist, and it is a muscle. So this diagram shows our chambers of our heart. we have 4 chambers. We have a right atrium, right ventricle, left atrium, and left ventricle. So there's unoxygenated blood, deoxygenated blood that comes from the body into the right atrium, to the right ventricle. Then it goes out to the lungs to become oxygenated. Once it's oxygenated, it comes back in the heart, and the left atrium goes to the left ventricle, and the left ventricle pushes oxygenated blood out to our bodies to perfuse our organs and our bodies. Now, in between each chamber, as the blood goes out, there are valves. These little white things are valves, and doctors keep an eye on these as well. It helps prevent blood from flowing back when it's pushed out. So when you're listening with the stethoscope or have your ear against someone's chest, you hear that thump, thump. Those are the valves closing. And it's important that they open efficiently, and they're not stenosed. They open easily, and it's important that they close, or they don't have any type of prolapse. They close completely so that the blood doesn't flow back. When you look at the outside of the heart, that's a muscle. And look around the left ventricle, you see that part is a little thicker than around the right ventricle, because this part of the heart is pumping blood out to our bodies. So it needs to pump, a little stronger to get the blood out of our bodies. Now, the heart muscle, it's important. This is why they want us to exercise, to keep our heart strong, because this muscle needs to be strong like any other muscle in our body. And we kind of talk about it like a rubber band. So when you stretch a rubber band at first, it comes back, it's really tight. But as you keep pulling that rubber band, it loosens up. So it's not recoiling, or it loses its elasticity. And so then you don't get that blood out of that chamber to the rest of your body. And that's when you have some heart failure. So that's what heart failure is. It's when the pumps aren't pumping efficiently. So definitely the purpose of our heart is to pump blood efficiently to our body. Now, ejection fraction, I'm sure people have heard of that, is the amount of blood that goes out of the heart, or the how well it pumps the blood out of the heart. It's never 100% because you don't get it all out of there, but 50 to 65% is a good EF, or ejection fraction. And then once those numbers drop, then you're going into, it's when these are clogged or blocked that the certain part of the heart doesn't get blood, and it can become damaged, or it can die, that part of the heart, and that is considered a heart attack. So it's when the part of the heart does not get the amount of blood that it needs. So when a part of the heart doesn't get the blood that it needs, then that also affects how it pumps. That can affect how it pumps. Let's see. Cardiac catheterizations are how doctors actually see if there's a blockage in the heart. They inject dye into, we have 3 main coronary arteries, the circumflex, the left aorta descending, and the right coronary artery. And if there's a blockage, it depends on how bad the blockage is. The doctors can treat with medication. They can use a balloon angioplasty with a stent, where they go where the blockage is and balloon away that plaque so that the blood flows through, and then they could put a stent in there. A cardiac stent, it's about the size of the little spring in an ink pen. It's about that size. And it's put in the artery, it's on a balloon, they inflate the balloon, and it's deployed in the artery so that the blood can flow freely. Now, if you have more than one blockage, or if the blockage is so bad they can't stent it, or if it's right here in the left main, then you may be a candidate for coronary artery bypass graft, which is a CABG. You may know of it as a CABG. It's open heart surgery. You take a vein from your calf, lower part of your leg, your calf, and they actually just connect it to your artery and have the blood flow around that part that is blocked so it can perfuse the rest of your heart. Okay. Now, that is considered our plumbing part. You know, we can't have a clogged pipe in our house, and you don't want to have a clogged artery in your heart. So the next part is our cardiac conduction system, which is the electrical part of the heart. And this is the part that an electrophysiologist, your electrician, would treat. So our heart has an electrical system where the impulses stimulate the muscle in the heart to make your heart contract. And so this has to work appropriately for your heart to beat. So our electrical system moves all the way through the heart. It starts right in the atrium. This top part is the SA node, is our natural pacemaker. So this is working appropriately. It initiates the contraction, and then the impulse just goes all the way through the heart and makes the top chambers and then the bottom chambers contract, and that blood flows out. If there is a problem with the electrical conduction system, then you could possibly need a pacemaker to give that impulse to make your heart beat. There are also, so that's a bradycardia, when your heart is too slow. There's also tachycardias, or fast heart rhythms that occur that can be treated, various treatments. Medication can slow down your heart rate. It depends on what it is. Atrial fibrillation, which a lot of stimulation in this top chamber of your heart can occur. And so cardioversions can treat atrial fibrillation. There are also ablation procedures where they put catheters up and actually burn part of the electrical cycle so that it doesn't excite too much and make your heart beat too fast. When your heart beats too fast, it doesn't pump out the adequate amount of blood. So, then you don't have the appropriate cardiac output when it beats too fast or too slow. Some arrhythmias initiate in the bottom chamber of the heart. And those can be lethal, because if you have impulses just going off in the bottom chamber of your heart is not contracting, and you're not getting the blood to your brain, to your organs, to your extremities, and those can be lethal problems. So like I said, electrophysiologist is a specialist that you would be referred to if you have problems with your conduction or electrical part of your heart. So there are various diagnostic tests that can tell how your heart is working. And most of us are familiar with an EKG, electrocardiogram, or EKG. A lot of us have had that, when you put your stickers on your chest, and then the doctor can see your heart rhythm from different views, 12 lead EKGs, 12 leads, 12 different views where they can see what's going on with your heart. They can tell if you've had an old heart attack. Maybe people say they didn't know they had a heart attack. Or if you're actively having a heart attack right now, there's certain changes in your EKG that they can tell. If you're in heart failure, there are changes. So it's all kind of things that they can tell by the EKG. And that is non-invasive and very easy to do. It can be done pretty much anywhere to get a 12-lead EKG. Next is a stress test. So a lot of times if they see changes in the EKG, then they refer you for a stress test. So stress test is what it says. It's stressing your heart. So a treadmill, people who can walk on a treadmill, you're put on a treadmill or exercise bike, you're hooked to an EKG, blood pressure, a pulse oximetry. So your breathing and your blood pressure and your rhythm are being monitored while you walk on the treadmill or while you are on an exercise bike. It stresses your heart to see how your heart responds to the stress. It can tell if you have changes when you stress your heart, can be an indication of some coronary artery disease. If you are unable to walk on a treadmill, let's say you have bad back or whatever, then there are there are medications that can be injected that can then stress your heart or act as though you're going through that motion of exercise, so they can tell the how your heart responds when under stress. Now, if there are changes there, then you might have to have a cardiac cath, but that's on down the list, so I'll talk about that. But next I have echocardiogram, or an echo. Sometimes we just call it an echo. It's very similar to a pregnant lady, a sonogram, where they put the gel and they can see the baby, the sonogram. What this is done on the outside, it's non-invasive, where your heart, they can evaluate the chambers of your heart, they can evaluate the valves, all by using sound waves. So that's an echocardiogram. Next is a TEE, transesophageal echocardiogram. This is where a tube is put down your throat, similar to when you have an EGD done when you're looking in your stomach, but the tube doesn't go all the way in your stomach, it stops around your heart, and it's a little bit thicker tube where your heart can be evaluated even closer. It's a better look. So sometimes this is done when you're looking for clots. A lot of time, if a patient is in atrial fibrillation, a doctor wants to cardiovert them and convert them into the regular rhythm. You don't want to do that if they have a clot in their atrium, a clot in the chamber of the heart. So they do the TEE to get a close look to see if there are any clots. Sometimes if someone has an infection and they don't know where it's coming from, they want to look at the valves. They can see if there's any infection or anything on the valves. They can do the TEE. They can look at chambers of the heart. They could tell all kind of information with the transesophageal echocardiogram. Next diagnostic test, there are Holter monitors, event recorders, and loop recorders. All of these are looking for heart rhythm changes. So you may feel palpitations, or you may start feeling faint at times, but when you go in the doctor, your EKG or your rhythm strip is normal. So to find out, maybe you're going in and out of some type of rhythm, then a Holter monitor. You start with the Holter monitor. It's a monitor, you put the EKG, not 12 leads, most of the time it's just 5 leads on with the little monitor, and you wear it for about 24 to 48 hours, and it just records your rhythm. And then the doctors look at it, or the tech looks at it to see if there are any changes in it, tachycardia or bradycardia, or if you have any rhythm changes. Event recorder is similar to a Holter, but you can wear it for several weeks. And that can be set up where when you're feeling those symptoms, you actually hit the button so it records. Let's say you have dizzy spells or you feel those palpitations, you hit your event recorder and it can record and download, and then you can download the recording to your cardiologist's office and they can take a look. Loop recorders go even farther. They are little small, skinny little, almost like one of those, I forget what they're called, little things that you put in the computer to get the data. And it goes right under your skin, right in the middle of your chest, right under your skin. They're loop recorders, and you can keep those for 2, I've even seen people keep them for 3 years. And these new loop recorders, you can actually use your cell phone to activate it when you're feeling any symptoms. The loop recorders can also be set to record when it notices your heart rate going down or going up. So it can have a bradycardia and a tachycardia trigger that it will record when your heart rate goes too low or too fast or becomes too irregular. And then you can tell if that's a time where you had some of those symptoms and try to figure out what's going on with your heart rhythm that way. And so like I said, those you can keep for 2 to 3 years, and they are implanted in your body, but they're really tiny. You can't hardly tell that they're in there. So the next test is the cardiac catheterization. A lot of people have heard of this. And that is when you go, it's invasive. to the hospital, to the cardiac catheterization lab, and a catheter is put into your artery and dye is injected. And so this picture that I have here actually shows 2 of the 3 coronary arteries during a cardiac catheterization. This is how it shows up on X-ray. Once the dye is injected, then we use X-ray to actually record the picture. And if you can see, I don't know if it's coming up clear enough, right here, right above where my mouse is, my cursor is a very pinched off part right in there. So that would be a place where they would put a stent or do balloon angioplasty if they could. See just how tiny that is. And also right in here, that area looks narrow as well. So they may try to do balloon angioplasty, but this is how it comes up. And the cardiologist can take a look and see if there are any narrow places. Right here in that area, if you could see where my cursor is, it's called the left main. And I don't know if people have heard of the widowmaker. If this is blocked, then it blocks the blood flow to the majority of your heart. And a lot of people do not, though I've heard of people, definitely heard of people surviving it. But this is a very dangerous place to have a blockage. If you have more than one blockage, or if your blockage, like I said, is severe enough, then they would could be a candidate for a bypass, and where they would just bypass the blockage, connect the vein to that artery, and then connect it around the blockage so that the rest of the heart can be perfused with blood. Okay. You can also, during a cardiac catheterization, the doctors look at your ejection fraction, so the chambers of your heart and how they're pumping. They can take a look at your valves, and they can measure pressures, your heart pressures. So the pressure in each chamber, there's certain parameters what they should be. And so those can be measured as well during a cardiac catheterization. Next on the list I have is an electrophysiology study. So this is the electrical part, EP studies. We used to do these all the time before patients got defibrillators, but they've kind of changed those guidelines. And if you have a low EF and have had a heart attack, then you can get a defibrillator. But we used to have to have a positive electrophysiology study before you can get it. Those defibrillators for patients who are prone to arrhythmias. But the EP study evaluates the electrical part or the conduction part of your heart. Catheters are put in the vein in your groin area. Same with the cardiac cath. The cardiac catheter is put in your artery, and they do the groin, and now they're doing the radial artery in your wrist where they can put the catheter in. But most of the EP studies are done with a vein catheter in your groin area, and they put the catheter up into your heart and stimulate that muscle. And it's just an algorithm that they go through to see how your conduction system works. And so you can tell if you need a pacemaker, if you need a defibrillator, if they induce any type of arrhythmias during that. So the EP studies are very helpful to the electrophysiologist. This last diagnostic test is a tilt table test, and this isn't used that much, but it's still used sometimes for people who have fainting spells or syncope to see what's going on or why they're having the syncope. It could be vasovagal syncope. So you're really put on a table, and it's in a quiet, dark room, and you're tilted up on the table, and your heart rate and blood pressure are monitored. And you look for trends downward in the heart rate and blood pressure. And sometimes it's sudden and the patient will pass out. But once you're flat and the blood's back to your brain, patients come to. So it's a very simple, non-invasive test that is used as a diagnostic tool. Also, something that I hadn't put on here, but it's blood work. So blood work, there are levels that are taken that can tell how your heart is working. Troponin levels, the levels that BNP levels that can tell if you're having heart failure. The troponin and CKB, it can tell if you're having a heart attack. And so people complain about all this blood, but what they do is you take blood, then a few hours later you take more blood, a few hours later you take more blood, and you see if there's a trend up. It should be a trend up and down if a patient is having some type of cardiac event going on. So those are levels that they take to help diagnose whether you need to go to the cath lab or what's going on. Now let's get into risk factors. We know a little bit about the heart. We know what it does, some of the diagnostic tests. Now, risk factors. These risk factors, people who have these are at a higher risk of having heart disease. So let's start with blood pressure. High blood pressure or hypertension is also known as the silent killer. And it's called that because sometimes by the time people realize they have it, a lot of irreversible damage is already done. High blood pressure is when the pressure of the blood going through your veins are too high, and left uncontrolled can cause damage to your organs. Now, another American Heart Association statistics says that the occurrence of high blood pressure in African Americans is higher than anyone in the world, not the nation, the world. So this is something we just have to get under control, is this blood pressure. Normal blood pressure is less than 120/80. And I know that seems kind of low for some people who have high blood pressure. And of course, if you have a high blood pressure, you can't expect the doctor to just drop your blood pressure quickly. It will be a gradual decline to try to get you as low as possible, but less than 120/80 is considered normal. It's important to have your regular checkups with your doctor. Try not to miss appointments. Even invest in one of the home blood pressure monitors, and take your blood pressure every day at the same time. Sit there for about 5 minutes and record it. And that'll be very helpful when you go back to your healthcare provider so they can see what you are usually trending. A lot of people, once you go to the doctor to have your blood pressure checked, your blood pressure goes up. If you take it every day and have a log, then that tells really what's going on. Please be consistent with your medications and take them as advised by your healthcare professional. I've heard people say, well, but I'm not taking that anymore. My blood pressure's fine. Well, it's fine because the medication is what's helping it. But a lot of people think that, and they stop taking their blood pressure medicine because, their blood pressure's fine. They don't think they're needed. But yes, you do need it. Also, blood pressure medications can be expensive. Communicate with your healthcare provider. There could be other options, generic options, another pill altogether that will help. Ask for samples when you go to your doctor's appointment. Just please don't stop your medications. A lot of the blood pressure medications are very reasonably priced these days. So communicate with your doctor. They may have coupons or some programs that you might be able to get into that can help you afford the medication. Also, don't wait until you're out of medication before you do a refill. There are a lot of 90-day refills you can do, but make sure you refill your medications when you see that you're getting low, not that when you're out. I hear patients all the time say, oh yeah, I need to get a refill on that. I ran out. Well, pay attention. You're taking it every day, and call in your refill so that you won't miss out on taking that medicine. So blood pressure, something we really need to work on. Foods that are low in sodium. When you have salty foods, a lot of sodium, it makes your body hold on to water and fluid, and that increases your blood pressure. So low sodium foods. Walking every day. Walking is very beneficial. 30 minutes a day. Doesn't have to be very fast. can help lower your blood pressure and help keep that heart muscle strong as well. Next is diabetes, or high blood sugar. Diabetes is when our body doesn't make enough insulin or doesn't properly use the insulin that is made. And so we use insulin to move glucose or sugar to our cells for our body to have energy. And so when the insulin isn't working right, or we don't have enough insulin, that causes us to have a high blood sugar. Diabetes can damage blood vessels and nerves of our heart. And over time, it can increase our risk for heart disease, especially when it's uncontrolled. Diabetics often get heart disease or diagnosed with heart disease younger than people who don't have diabetes. So it's important, if you have it, to control it. You have to watch the bread that you eat, because bread and carbs turn to sugar. You already have enough sugar or too much sugar in your body. Eating sweets. There are all types of alternatives now to sugar that will make food taste better for diabetics, so that you're not supposed to eat a lot of sweets, but there are a lot of alternatives that you can use to get that sweet taste, I guess, every now and then. But it's very important to control your blood sugar. Diet control, also medications, oral medications for some diabetics, and injections of insulin. Hemoglobin H1C is a blood sugar, a measure of your blood sugar over time. So that's a measure of the past 2 or 3 months. So sometimes your doctor will have you come in doing a fasting blood sugar. That means you haven't eaten for 8 hours prior. Eat or drink for 8 hours prior. So usually those are the early morning doctor's appointments. And you don't eat, past midnight, and you go in and get your blood sugar test. And that fasting blood sugar less than 100 is normal. But hemoglobin A1C, 5.7% or less is normal for that hemoglobin A1C. Next risk factor is high cholesterol. So cholesterol is this like waxy, fatty material that we have in our body and that our body makes, or liver makes cholesterol. So it actually makes enough. We just get extra from eating those foods and saturated fat, those fatty foods, trans fats. It gives us more cholesterol. So then we have more than we need that's flowing through circulating through our blood. And that can clog those arteries so that you don't get the amount of blood to your heart that you need. So that is the risk for that high cholesterol. High cholesterol can be controlled with diet and exercise as well. And some patients are put on statin drugs to help control the cholesterol. You have low density lipoproteins, which is your LDL or your bad cholesterol. You want to keep that below 190. You have your triglycerides. This is another cholesterol measurement that is not very good. You don't want that to be greater than 150. And then you have your high density lipoprotein cholesterol. That's what we call good cholesterol. So sometimes your doctors, they always draw all of these panels, and can sometimes, if your high density lipoproteins are high enough, but your low is still a little high, kind of balances it out. But you want your good cholesterol to be up, and the bad cholesterol, which is your low density lipoproteins, you want that to be low. So those are the measurements of your cholesterol. And the only way to really know if you have high cholesterol is blood work. No other way to know other than drawing your blood work. So again, following up with our doctors, having our yearly appointments, or however often they tell you to come back, to keep an eye on your levels and being consistent with your medication. Next risk factor is obesity. Obesity is excess body fat. Now, obesity can lead to the high blood pressure, diabetes, and high cholesterol. So that's what makes it a high risk factor for heart disease, because it leads to all these other things. And we control it with obesity with lifestyle changes, diet, and exercise. A loss of 3 to 5% of our body weight helps reduce the risk of heart disease. So that, if you take 3 to 5% at a time of your weight and try to reduce that, just think you're helping yourself pretty much a lot just by losing 3 to 5% of your body weight. The next one is smoking. It's one of the worst things we can do to our bodies. I'm telling you, I'm passionate about this. I preach all the time to my patients, and I know it's hard to stop. But smoking damages our heart. Smoking damages our vessels. The carbon monoxide in cigarettes decreases the amount of oxygenated blood that we can send to our bodies, to our body parts, to our organs, and to our brain. Also, the nicotine in cigarettes increases our blood pressure. So it's all around just bad for you. Secondhand smoke. So if your family members don't smoke, but you smoke, the smoke that they are getting from the secondhand smoke can make their risk for heart disease increase as well. So there are all kinds of ways to stop smoking that your doctor can help you. I know some people can go cold turkey, but really the nicotine, it's an addiction. People get used to, having to smoke, not just your heart, but your lungs, your kidneys, your whole body. So your blood vessels will able to flow the blood to your body. Also, genetics. Genetics is one that we cannot control. Genetics or heredity, family history of heart disease, we can't control it. But if we know we have a family history, we can be on top of the other risk factors. Make sure we eat right and exercise and keep our blood pressure and cholesterol and weight and diabetes and don't smoke. Keep all of that controlled, especially if you have the genetics or the family history, because that is completely out of our control. And I wanted our signs and symptoms to be at the end of my talk today, because I want it to be fresh in your mind when we leave. So these signs and symptoms, we just cannot ignore our signs and symptoms. So we think of chest pain, just like an elephant on our chest, as being the signs and symptoms of a cardiac event. And it is, but also chest tightness, chest pressure, chest discomfort. I've asked patients, are you having any chest pain right now? No, no chest pain, just a little discomfort. But that is something that should not be ignored. Women are a lot of times don't have the chest pain. They may have a little discomfort or a little tightness. They can present differently. So please don't ignore any of the chest problems or chest pressure, anything that you feel. Talk to your doctor, okay? Shortness of breath is another symptom of heart disease. It could be of heart failure. Your body is not circulating that blood appropriately. Nausea and vomiting. Patients present with some chest pain and nausea and vomiting, or nausea and vomiting can be indicative of a cardiac event. Heartburn and indigestion, sweating, dizziness, pain in your jaw, in your neck, in your arms, in your upper back. I've had people tell me they just had pains in the center of their back at the top, and it was a cardiac event. Extreme fatigue, or being really, really tired, very tired, is a sign and symptom. And swelling in your ankles and legs can be a symptom of heart failure, or that you're not getting that blood circulating as needed. So none of these symptoms should be ignored. And especially if you have risk factors, heart the blood pressure, diabetes, high cholesterol, mention these to your doctor. And of course, excuse me, if you're having extreme chest pain or discomfort and shortness of breath, you can't breathe, call 911 and get some help, because time is of the essence when it comes to your heart. You want to correct any blockages or anything that you have before that muscle is damaged. Once it is damaged, once it is infarcted, there's no way of reversing it. Okay. So please keep your doctor's, oh yeah, you are having a little indigestion, stop eating this, that, or the other. And the worst it could be is not your heart, So if it is your heart, you want to get help for it. Okay. All right. And that is it. I'm going to stop sharing. If anyone has any questions.
Chanda, wanted to know the exercise part, and especially as you get older, you do gain weight. However,
Yeah.
the heart being a muscle, which we know,
Mhm.
Can you talk more about the importance of exercising because the heart is a muscle?
Yes. So, like I said, the heart is a muscle, and you want to keep the heart strong because it's pumping the blood to your body, to your brain, to your organs, to your extremities, to your lungs to become reoxygenated. And if that muscle isn't strong, if that muscle, atrophies, if we don't use our muscles, then they don't work appropriately. So exercising and walking, and those who have heart problems already, you definitely need to talk to your doctor first so they can tell you how much exercise to do. But walking regularly will keep those muscles strong, that heart muscle strong. And remember the analogy I used with the rubber band. If we don't keep our heart muscle strong, it loses that elasticity. So it's not pumping strong to get the blood out of your body. So it is very important to at least 30 minutes a day. Actually, start off with 10 minutes. Some type of movement daily is very important for our heart.
Chanda, we had a little problem with your audio during the symptoms.
Okay.
Slide.
Okay.
So maybe you should
Go back.
go back over the symptoms.
Okay.
And
I'm going to see. Do you want me to see if I can share again?
yes.
Okay. Okay, there it is. Can you hear me?
Cynthia was.
Oh, is she saying something?
Chanda, Cynthia was saying something.
Yeah, but she wasn't coming through clearly either.
Oh.
Can you repeat it on Cynthia?
I can. Can you hear me now?
I can, yes.
Okay, I was just asking you about sleep apnea, and you can do that after going over the symptoms again.
Mm-hmm. Okay, let me go ahead and talk about it. Sleep apnea, that's a very good question. A lot of people have sleep apnea, and a lot of people ignore sleep apnea because they don't like wearing the machine. Sleep apnea can cause all kinds of problems, any part of your body, but especially your heart. It can be, it's directly in correlation with atrial fibrillation, which is an arrhythmia of the heart. You're not getting the blood that you need to your heart, and it definitely affects the function of your heart. So sleep apnea, for those who aren't aware, is when you're asleep and you stop breathing. You stop breathing in your heart. You snore. People who snore really loudly, or you wake yourself up when you're sleeping and you snore so loud you wake yourself up, that's definitely a sign of sleep apnea. A CPAP machine is usually the treatment for that, and a lot of people think it's not comfortable, but nowadays we have they have many more types of masks, just the one that goes up your nose, like oxygen tubing. There's just very different types of masks that are more comfortable. If you try one, then and it doesn't work, try another one. And I think every 6 months, maybe you can get a new mask. So if you try it for a few months and it doesn't work for you, then get another one. But it's really important. And thank you, Aunt Cynthia, for mentioning sleep apnea as being a risk for heart disease.
Can I just say one thing?
Yes.
This is Lily Harris, and I do have sleep apnea, but I don't use a CPAP machine. There are also dental appliances that you can get.
There are, depending on how severe your sleep apnea is, yes. So if you have mild sleep apnea, you're right. There are dental appliances that you can use in your mouth. Absolutely. Absolutely. Some people can just have their tonsils, it might be just occluding your airway with your tonsils. And once they're removed, you're okay. But you're right. There are some people who can use the dental appliances, and those are for milder cases usually.
Can I ask a question also?
Yes, ma'am.
What about asthma? Is that considered or combined with sleep apnea?
Usually asthma is different from sleep apnea. Usually asthma is when there's wheezing in your lungs and your airways kind of narrow. Sleep apnea, you stop breathing in your sleep. Your oxygen saturation drops. You just stop breathing. And the treatment for that is the CPAP when you're sleeping. Whereas with asthma, excuse me, it's inhalers or there's Singulair, those type of medications that help with that. So those are separate, and you might could have both of them together, but they're different.
Okay, thank you.
Yes, ma'am. Now, back to the signs and symptoms that a lot of people didn't hear. So I started with the chest pain, and we think of chest pain, crushing chest pain, puffing on our chest as being the sign of cardiac event, and it is a sign, but it's not the only sign. Chest tightness and pressure and just some discomfort in the chest is also a sign. And like I said, especially in women present different than men sometimes. Also, sometimes diabetics present different, where they don't really feel a lot of chest pain or tightness. They may feel a little discomfort. So I just don't want anyone to ignore even discomfort in the chest and think, well, that's a little something. I don't think it's anything. It's worth it to get it checked out. Shortness of breath is another symptom, because if you have heart failure and if your heart isn't pumping efficiently, then you're not getting the blood, and you can retain fluid. You're not getting the blood circulating like you need, and it can actually back up in your lungs, and you can have shortness of breath. Nausea and vomiting is a sign. Heartburn or indigestion, sweating, profuse sweating, and dizziness. The dizziness, you're not getting the blood to your brain that you need. Pain in the jaw, in the neck, in the arms, upper back. I've had patients that just had pain right in the middle of their back, and it was a cardiac event. Extreme fatigue. Fatigue is being very tired, just drained and tired. And swelling in the ankles and legs. And that goes back to, that's definitely a symptom of heart failure. When you have the swelling in your ankles, you're not getting that blood flowing like it should. So those are the symptoms, and especially the symptoms with risk factors. You should definitely talk to your doctor if you're having any of that.
Hey, Chanda, it's Alan.
Yes.
Can you hear me?
Yes, sir.
Hey, so thanks again for doing this. can you tell us, and maybe you said this up front and I missed it, do you currently work in the hospital, or are you in a physician practice office? Are you in a cardiologist's office? Or are you in a primary care physician's office? And just your take on the current state of affairs in terms of, do you find that patients are at least now back seeking care? Because I think, like, when all the COVID stuff hit, a lot of people went to like virtual appointments and maybe they weren't getting the care that they needed. So any thoughts there?
Well, currently I work in a hospital, and I work where I prep patients for cardiac surgery. I have worked in doctor's offices, and I've worked in the cath lab and ICU, coronary ICU in the past. So there were times when patients weren't coming in the hospital, and we're seeing the results of that now. We're seeing people, a lot of bypass, and you could tell that people had not been coming, had been afraid to come to the hospital, to their doctor's appointments, missing doctor's appointments because of COVID, afraid to come in. So we were seeing not just heart problems, but all kinds of problems. I mean, in the OR, tons of brain tumors and everything, because people just weren't getting checkups. But I think now people are more are feeling better about going, I think.
Thank you.
And also, COVID increases the risk of heart disease. There was an article in Lancet, which is a medical journal, that says it increases like 3 to 8 times more likely. So that's my plug for getting your vaccine. It's important that we get our vaccines. It's like clotting cascade or whatever. People are at higher risk of stroke and cardiac events once they're diagnosed with COVID. So please get your vaccines. Any other questions?
And speaking of exercises, how is stretching? Stretching your body, your legs and your arms, just stretching.
Well, any type of movement. I was actually reading something that says 10 minutes of any type of movement is better than sitting on the couch watching TV. So any type of movement. I know, especially when my back hurts and I stretch, I feel my heart rate going up sometimes, depending on some type of stretching that you're doing, whatever type of stretching you're doing. So any type of movement is a start. And the more you move, then the more, your body becomes used to it, and the more you'll be able to do.
Okay, thank you.
But like I said, if you do have heart problems now, talk to your doctor so you'll know what is safe for you, how much exercise is safe for you.
Yes. Thank you.
Chanda.
Yes,
This is
ma'am.
Cynthia. Do you find that a lot of young people are on high blood pressure medications? And if so, is that because of genetics or what?
Yeah,
I know a young man who's just been put on high blood pressure medication, and he's 27, and I thought very healthy.
Ooh, 27 is young. 30s, I see a lot of 30s on blood pressure medication. And stress plays a role in this as well. And we're all stressed out during these times. So, I don't know how much, but I know it does play a role. So there has to be, I don't know, we have to kind of try to figure out how to reduce our stress and just relax. And all of that increases your blood pressure when we're stressed. Now, I don't see a lot of 20-some-year-olds on blood pressure medicine, but definitely see some 30-year-olds and 40-year-olds on blood pressure medicine. Unfortunately, because I'm in my 40s, I think that's young, but it's, you know, I do see a lot of that. I think with weight control and exercise, some people, if they try with that, you know, could be a possibility of helping out with blood pressure. But it is very prevalent.
Are there any more questions from anyone who is tuning in?
I have one. I have a question.
Okay.
I'm asking, you mentioned COVID, and I know some persons who had heart attacks and passed while they were in the hospital or had been hospitalized with COVID, and they passed from heart attacks and COVID, I guess. But my question is, was the heart problem, well, were the heart problems there before the COVID and it just made it worse, or the COVID produced a side effect of COVID? Which is?
So in reading, I know that if you already have heart problems and the COVID can increase those risks, but there also is a type of kind of clotting cascade that goes on in our body that I have read that COVID initiates the clotting. And so, of course, a heart attack or a stroke is a clot to a vessel in your brain. A heart attack is a clot or a blockage to your heart. So it is actually increased risk of a heart attack by being diagnosed with COVID, even if you hadn't been before, from what I have read. And that Lancet article journal says it's 3 to 8 times higher.
Thank you.
Yes, sir.
Chanda,
Yes, ma'am.
I have heard and have been told many times that coffee, especially caffeinated coffee, is very good for heart health. And then I've heard the opposite train of thought that says that coffee is detrimental to heart health. What is your stats on that?
I don't have any stats on that. I can actually research that and get back with you. I know that with caffeine, it increases our heart rate. So I can see where that the negative part of that, but I do not have information on the positives or anything with caffeine in heart. So I will get that information. Is this Reverend Thomas?
Yes.
Okay, I can email you some information.
Okay, that would be fine. Thank you.
Yes, ma'am.
Excuse me, I'd like to ask a question. This is
Yes, ma'am.
Marie Dixon. And I'd like to know, when a doctor takes you off of heart medication or blood pressure medication or any type of medication, should they recommend you come back in 3 months? Can't that be, a lot can happen within that time?
I would think they would want to see you back. I mean, I don't know the specifics, but I would think that they would want to see you back. I don't, you know, it just depends on what's going on, whether 3 months or 6 months or. But usually they do want to follow up with you. I do agree with that.
They take you off of cholesterol medication.
Off of cholesterol?
Yeah.
So cholesterol, you know, they could see you in a year and check your cholesterol again to see if it's still low enough for you to be off. Evidently, you've been controlling it well with diet and exercise. and your levels were low. And so I'm sure he will follow up with you, or did he say he will follow up with you in 6 months to a year?
Well, actually, being put on a cholesterol medication, it was discontinued. So by the time I saw the doctor again 3 months later, he said, "Oh, you're gonna have to go back on that cholesterol medicine because I don't want you to have a heart attack."
Ooh.
So I would think that it was like 180, but I would think that when they make a change, they should check on you a little more often to see what it's doing.
I agree. So
Chandra, you're going to need to repeat yourself.
I can't hear you.
Yeah, pause for a moment. Now can you start over again, Chanda?
Internet was unstable.
Yes.
Okay. So that's what I would do is
start back at the beginning of your comments.
Ma'am, sir?
Chanda, start back at the beginning of your comments to her.
Okay. So I would contact the doctor's office and talk to his nurse and tell her your concerns and go in. Tell her you want an appointment to go in and be checked out. I mean, you have to be an advocate for yourself. Definitely. And if you feel like you'll feel better to be seen, to make sure that the medicine is working appropriately, then call the nurse and talk to the nurse and get on his schedule and go in.
Okay. That's what I did do, but just for my information for others, some of us rely on our doctors and we trust them.
Yes, ma'am.
So we don't question. If he says 3 months, you figure, okay, it's okay. But by the time you get back, it may be something that has changed. So thank you for that answer.
Yes, ma'am.
Any more questions? We have reached that hour mark. I don't want to leave you out, but if you have a question, please go ahead and unmute and ask, and then we'll close.
Very good. It was very good.
Thank you.
Thank you, Chanda.
Thank you.
Thank you, Chanda.
All right. Thank you all so much. Thank you, Mrs. Hicks.
Thank you.
Thank you. It was very informative.
Thank you.
Take care, everybody.
Have a good week.
Thank you, Chanda.
Thank you. It was wonderful. Thank you.
Well, thank you.